Let me ask you something direct. When did you last feel like yourself? Not medicated, not managed, not controlled on paper, actually like yourself. Because here is something that does not get said clearly enough in most consultations. If you are over 60 and on blood pressure medication, some of what you are calling aging may not be aging at all. It may be your medication. And the difference between those two things is not small. One of them you cannot change. The other one you absolutely can. I am Dr. Zion Adetola, and today I want to walk through 3 blood pressure medications that are still extremely common in older adults and that carry side effects which look so much like normal aging that most people never stop to question them. Atenolol, Hydrochlorothiazide, and Amlodipine. These are not rare drugs. They are on formularies everywhere. They have been for decades, and for some older adults, they are quietly making life harder in ways nobody is connecting to the prescription. Before we go any further, one thing must be clear. Do not stop any blood pressure medication on your own, especially not Atenolol. Abrupt withdrawal from a beta blocker can be dangerous. If you are on heart medication of any kind, any changes need a careful, structured plan with your doctor, not a sudden decision. What I am talking about is slower than that, smarter than that, a conversation, a review, a willingness to ask whether the prescription that made sense years ago still makes sense now. In this body, at this age, with these kidneys, this circulation, and these goals. That is deprescribing, not reckless stopping. A structured, supervised reassessment of whether each medication is still earning its place. Let's start. Medication 1, Atenolol, also sold as tenormin. Atenolol is a beta blocker. It has been on blood pressure lists for a long time, particularly in older adults who were started on it years ago and never had a formal reassessment. On paper, the logic seems clean. Slow the pulse, lower the pressure, move on. But the body is not a paper chart. Atenolol can make the blood pressure number on the arm cuff look well controlled while doing something else entirely to the rest of the cardiovascular system. Because a cuff only measures one thing in one place. It does not tell you about central aortic pressure. It does not tell you about arterial stiffness. It does not tell you how your circulation actually behaves when you stand up, climb a flight of stairs, or carry your shopping bags. So a person hears their pressure looks controlled and still feels like their body has lost something. Their energy is lower. Their legs feel heavy. Exercise that used to feel manageable now feels like effort. They stop doing things they used to do without thinking about it. And quietly, almost imperceptibly, they start calling it age. Here is the specific problem. Atenolol blunts the heart rate response to exertion. Your heart is supposed to adapt when you need more oxygen. You walk faster and the pulse rises. You take the stairs and the pulse rises. You carry something heavy and the pulse rises. That is not a problem. That is the cardiovascular system doing its job responsively. Atenolol can flatten that response. And for some older adults, that flattening feels exactly like becoming old overnight. They say, I cannot recover after a short walk. They say, I feel flat. They say, I used to be able to do more. They say, maybe this is just what 65 feels like. Sometimes it is not 65 at all. Sometimes it is the drug making normal physical life feel abnormal. There is another layer. Atenolol can affect insulin release from the pancreas in susceptible individuals. And that matters because older adults are already more likely to be drifting toward insulin resistance. These changes do not announce themselves loudly. Fasting glucose creeps upward, energy drops, appetite and fatigue shift slightly, and because the decline is gradual, nobody connects the dots. I am not saying atenolol causes diabetes in everyone. I am saying that in some older adults, it can push glucose regulation in the wrong direction. And that deserves a second look when the numbers and the symptoms are moving together. Here is the question that should be driving this conversation. Not, is this drug lowering my pressure? That is a narrow question. The better question is, what is this drug doing to my whole system? And what is the cost of keeping it? If your resting pulse is always artificially suppressed, if your energy is consistently lower than it used to be, if stairs feel harder than your fitness level explains, and if your glucose numbers have been drifting, Atenolol deserves a formal review. Before your next appointment, write down 3 things: your resting pulse, your energy level across the day, and whether you feel more breathless, more sluggish, or less capable than you did 2 years ago. Then bring that note to your doctor and ask something direct. Could atenolol be contributing to my fatigue or my glucose pattern? And is this specific beta blocker still the right choice for me? That is how a deprescribing conversation begins. Not with panic, with evidence. Medication 2, Hydrochlorothiazide, HCTZ. A lot of people hear water pill and immediately think of it as harmless. The word sounds mild. The reputation sounds routine. But routine is not the same as neutral. HCTZ lowers blood pressure, partly by helping the body shed sodium and water. That sounds useful. And sometimes it genuinely is. But every time you shift fluid balance, you also risk shifting electrolytes. In older adults, that risk matters more than most people realize. Potassium is not just a lab number. Potassium helps regulate heart rhythm, muscle function, and nerve signaling. When potassium drops too low, the heart can become electrically less stable. Some people feel palpitations. Some feel weak. Some get leg cramps that wake them at night. Some just feel vaguely wrong in a way they cannot put a name to. Then there is magnesium. Magnesium is one of those minerals people ignore until the body starts complaining, in several different ways simultaneously. Sleep gets worse. Muscle tension rises. Fatigue deepens. Cramping appears. And over time, low magnesium status has been associated in research with vascular consequences that older adults absolutely should not dismiss. I want to be precise about the language here. This is not a dramatic process. This is gradual biology. Small mineral losses, repeated consistently over months and years, can become part of a much larger cardiovascular pattern. HCTZ also carries another issue that is significantly under-discussed. It can increase photosensitivity, the skin's sensitivity to ultraviolet light. Observational studies have linked long-term thiazide use to a modestly higher risk of certain skin cancers, particularly non-melanoma types, likely through this photosensitizing effect. That does not mean every person taking it will develop a skin problem. It does mean the drug has a wider biological footprint than the words water pill suggest. There is also a trap that keeps people stuck. If HCTZ makes someone urinate more frequently, they assume it is doing its job properly. But the body is not only about removing fluid, it is also about preserving mineral balance. A drug can lower blood pressure through fluid loss and still create hidden instability if the mineral shifts are not actively monitored. That is why older adults on HCTZ should not only be monitored for blood pressure readings. They should also be watched for rhythm symptoms, leg cramping, weakness, unusual fatigue, and any signs that the medication is quietly tipping the system off balance. And when someone says it is just aging, pause there. Age is real. But age is not a diagnosis. It is a context. It tells you to look harder, not to stop looking. The right labs matter here. Ask about potassium. Ask about magnesium. If your doctor agrees it is clinically appropriate, ask whether red blood cell magnesium would provide additional information. Because serum magnesium alone can miss part of the story. And ask about kidney function, because if the kidneys are not clearing efficiently, a diuretic can behave very differently than it did when you first started it. Medication 3. Amlodipine, also sold as Norvasc. Amlodipine is a calcium channel blocker, and it is prescribed widely for good reason. It can lower blood pressure effectively, and in the right person, it is a genuinely useful medication. But amlodipine has a very predictable, very consistent downside. It relaxes peripheral blood vessels, and in some patients, that relaxation causes fluid to shift into the surrounding tissues, particularly around the ankles and lower legs. That is why many people on amlodipine notice swollen feet by evening, puffy ankles, shoes that fit in the morning but feel tight by afternoon, a heavy, thick feeling in the lower legs that was not there before. The swelling is not random. It follows the physics of circulation. When the small peripheral arteries open up, pressure patterns shift. Fluid is pushed more easily into the tissues, particularly when standing or sitting for extended periods. And this is where the prescribing cascade begins. Someone notices the swelling, assumes it is poor circulation or simply aging, and adds another drug to manage the side effect. Now the patient is taking one medication that causes vasodilation and a second one to deal with the swelling the first one caused. That is not careful medicine. That is a cascade. And sometimes the better move is not to keep adding medications. Sometimes the better move is to ask whether the original drug is still the best class for this patient, whether the dose is too high, or whether a different option would fit better. Because when peripheral vessels open too much, the fluid dynamics change in ways that affect more than just appearance. Daily ankle swelling affects walking. It affects balance. It affects sleep. It affects how a person feels about their own body. And daily physical discomfort is not a small detail when you are 72 and trying to stay independent. I want to say this clearly. Amlodipine is not automatically the wrong medication. Atenolol is not automatically the wrong medication. HCTZ is not automatically the wrong medication. The real question is whether each one is still the right drug at the right dose for the right person at this stage of life. That is exactly where medicine often gets stuck. Many older treatment habits were built around younger patients, older evidence, and the path of least resistance. Those habits persisted because they were familiar, not because they were ideal. Once a medication becomes routine, it stops being seen as a choice. It becomes background noise. The problem is that bodies do not stay in background mode. They keep changing. Kidney function changes. Liver clearance slows. Blood vessels stiffen. Water handling changes. Autonomic responses shift. The same pill can feel entirely different 20 years later. Let me make this real with a pattern I have seen in different forms many times. A man in his late 70s, still active, still walking regularly, still fully independent, but gradually, over time, he started slowing down. His legs felt heavy. He was tired before the day was half over. He gained weight around the middle without any obvious reason, and every time he mentioned it to anyone, the response was consistent. That is just age. His blood pressure numbers looked controlled on paper, perfectly managed by the numbers. What nobody had looked at carefully enough was the medication pattern itself. He had been on Atenolol for years. His resting pulse was always low. His energy was flat. His fasting labs were drifting toward pre-diabetes. And every symptom was being placed in the same available folder, aging. When the full regimen was finally reviewed, carefully, deliberately, with proper clinical supervision, the question became simple. Could the beta blocker be part of the problem? With a structured plan, not an abrupt change, Atenolol was transitioned to a more modern option that suited his current physiology better. And over time, the picture improved. His energy came back. His exercise tolerance improved. His lab trends moved in a better direction. He did not feel 20 again. That would be nonsense. But he felt alive again, clear again, capable again, like himself again. That is what good deprescribing does. It does not promise miracles. It removes avoidable drug. And his story matters because so many older adults carry some version of it. The drug is not always the same. The labs are not always the same. But the pattern repeats. A symptom gets labeled as aging. The medication never gets reviewed. And the person quietly adapts to a smaller life. That adaptation is dangerous because it feels normal. People stop noticing how much better they could feel. Now, let me give you the language for the appointment, because information without language is not useful. If you are on Atenolol and your energy and exercise tolerance have changed, say this: my energy and exercise tolerance have declined, and I want to understand whether Atenolol could be contributing. Can we discuss whether a safer or more modern alternative is appropriate for me? If you are on HCTZ and you have been experiencing rhythm irregularity, cramping, or unusual fatigue, say this: I would like to check potassium, magnesium, and kidney function because I want to make sure the diuretic is not creating a secondary problem I have been attributing to age. If you are on Amlodipine and your ankles are swelling, say this: I want to understand whether the swelling is medication related and whether Amlodipine is still the best class for my specific situation. That is calm. That is professional. That is exactly the kind of shared decision making a good clinician will respond to. You are not challenging your doctor. You are collaborating with them. You are saying, help me understand whether this medication is still earning its place. Here is what I want you to remember. The number on the arm cuff is one part of the story. A single data point, the body under that number, is the real story. Atenolol can make the pulse look controlled while your energy quietly disappears. HCTZ can lower pressure while shifting electrolytes and increasing risks most people never hear about. Amlodipine can relax blood vessels while pushing fluid into tissues in ways you feel every single day and eventually stop noticing. That is why the goal cannot be the number alone. The goal is the person. Can they walk without heaviness? Can they think clearly? Can they sleep through the night? Can they stand without dizziness? Can they stay active without feeling like their own treatment is working against them? Those are real outcomes. Those are what matter in daily life. If a medication improves a blood pressure reading but makes the body harder to live in, the conversation is not finished. So do one thing today. Write down the drug name, the symptom you have been attributing to age, and the lab you want to ask about. Bring that note to your next appointment. And if this video made you reconsider something you had already accepted as just getting older, that is exactly where better medicine begins.